Our first panel discussion, our first presenter would be Mitch Stripling. Mitch Stripling currently serves as the Assistant Commissioner for Agency Preparedness and Response at the New York City Department of Health and Mental Hygiene, where he manages units for planning, training exercises, risk analysis, and evaluation, among others. He has served in senior leadership roles across multiple citywide emergencies, including Hurricane Sandy, H1N1, the Ebola crisis, and the international epidemic of Zika virus. In 2017 and 18, he managed the health department's supportive deployments to Puerto Rico and the U.S. Virgin Islands. His unit has developed nationally recognized threat responses guides for 21 high-risk scenarios that could impact New York City, a data consensus-driven risk assessment methodology, a set of health equity-based recommendations for ICS, and an evidence-driven all-hazards planning database, among other nationally recognized models. Prior to working in New York City, Mitch worked for the Florida Department of Health. There, he helped plan and implement the responses to 6 federally declared disasters, including the 2004 record-breaking hurricane season and Florida's response in southern Mississippi after Hurricane Katrina. Our second presenter on this panel, I'd like to introduce the Honorable Dr. Rafael Rodriguez Mercado, who is currently the Secretary of the Department of Health of Puerto Rico, in which he has charge and the mission to design and implement the public health policy as encompassed in the government platform of the current administration. His agenda is based on 3 strategic pillars: a patient-centered health system, fair and accessible health services, and an emphasis on primary care and prevention. He serves as director for a renowned endovascular surgery program and was chancellor of the Medical Sciences campus at the University of Puerto Rico. Prior to his current position, he was a professor of neurosurgery at the School of Medicine and the director of endovascular surgery program at this institution. Dr. Mercado obtained a Bachelor of Science degree in chemistry and a Doctor of Medicine from the University of Puerto Rico. As a student, he received the Research and Student Awards, as well as recognition of the House of Representatives in 1988. He completed his specialty in neurosurgery after 7 years of traineeship at the University of Puerto Rico School of Medicine. Then he obtained a subspecialty in endovascular neurosurgery from the State University of New York in Buffalo, New York. In September of 2017, he was appointed Associate Professor in Surgery of Uniformed Services, University of Health Sciences of the Armed Forces of the United States. With this appointment, he joined the faculty of this prestigious military university. Until then, he had held the position of Command Surgeon of the United States Army Reserve in Puerto Rico. He is currently attending physician as neurosurgeon at Walter Reed Medical Hospital and Brooke Army Medical Center. And he wanted all of you to know that he's married to Wanda Santiago Pimentel. I hope I didn't say her last name wrong, sir, who is a medical technologist, and he's a proud father of a young university student, Raphael. Our discussant for this morning's panel is Captain Renee Funk. Captain Funk currently serves as the Associate Director for Emergency Management, Office of Director, National Center for Environmental Health, and ATSDR here at CDC. Dr. Funk received her doctorate of veterinary medicine from Iowa State University, her Master's of Public Health and Tropical Medicine from Tulane University, and her Master's of Business Administration from Georgia State University. She is a diplomat of the American College of Veterinary Preventive Medicine. Dr. Funk is a recognized expert in environmental and occupational health and emergency management. Her portfolio includes emergency management of chemical, radiological, and natural disasters. Dr. Funk recently served as CDC's incident manager for the 2017 hurricane responses. Please join me in welcoming Captain Funk, Dr. Mercado, and Ms. Stripling for this first panel discussion.
Good morning, everybody. I somehow when you give those bios, you never actually think anybody's going to read all of it. You know what I mean? All right, I'm going to stand in between the two microphones. Is that how it works? All right, just want to make sure that I have all the buttons right. Okay. Um, I'm going to tell a personal story today, which is a very limited story. And I feel that right now that I'm in very distinguished company. So I want to make sure that that it is heard in that sort of personal way. The reason I frame everything that way is that I work in New York City, but I'm from South Georgia, and I have family that I know of that were on the wrong side of the civil rights movement deep into the 21st century. And that's why for me and for us in New York City, when we do this work, we talk about health equity and what health equity means. But when we do the work in New York now, we want to be clear that what we're talking about is structural racism. Okay. Um, Health equity is a great set of intersections. There are a lot of things that are in there about functional needs and access. But the point of the spear is the structures of power that we've created in this society that have institutionalized bias, right? And that's led to a set of structures that make emergency response more difficult and in some ways dangerous. And that's what I want to frame my talk around this morning. When you have a disaster, the disaster isn't caused by the hazard. It's caused by the people the hazard impacts, right? The last presentations did a great job of framing that. But those people are where they are because the society has sort of created the institutions that put them there, generally. And that's why when you are coming in as a representative of a government, trying to help them, honestly trying to help them, and many heroes have worked in these responses, you are put back by that. That makes your work harder because you're kind of fighting the system. Does that make sense? Okay, so it's important to start with the question, do our emergency responses make these inequities that we're talking about better or worse? We cannot assume that we're going to make them better. In a lot of ways, we go in and sometimes they say the disaster after the disaster because the recovery effort sometimes creates issues that weren't there before. We have to be honest about that. And for us in New York City, this is a very personal story. This is not a story of me trying to come in and criticize other folks. When we did our Zika response, at the beginning of 2016, we, like every good public health worker and institution out there, started messaging for people to get tested. And so what you see here is the chart of our testing rates. And I don't know if you can see the quartiles, but as soon as we put out the messaging, the first thing we did was we distributed messaging around the city. Hey, city, go get tested. Who got tested? Well, the people that got tested were the lowest priority folks. They were the wealthy folks on the Upper West Side who were paranoid, who are not going to be traveling to Zika impacted countries. Right? And so we looked at that, and that caused us to take a hard, deep breath. And there were two camps of folks inside of our public health incident command system, because all we're talking about emergency management today. And one camp was, well, you know what? That's just the underlying inequities of the healthcare system, right? That's just our messages going out into the healthcare system. What can we do about it? And then there was the voice that said, you know what? That is our problem. And that's the voice that ultimately won. And what you can see over there is that we did 5 months of concentrated, resource-intensive work with our highest priority areas, the areas that would light up on the social vulnerability index, the areas of people who were traveling to these countries, but who also were lower poverty, who had lower rates of care. And so when the summer hit, we were able to flip our narrative, and the highest areas of testing were in large part the highest priority quartiles. But that took deep and intentional work and pushing of our commissioner for 5 months, because the incident command system that I'm proud of, that I helped to build, pushed against that, right? Because incident command is built on the idea of act, execute, execute, execute. And if you execute unintentionally, you will make the issues worse. You with me? I want to see, because you get sleepy. People get sleepy. Okay, so it's important when you're working in incident command not to work from an equality frame, because if you're distributing resources equally, those who have less will continue to have less, but to figure out and use these vulnerability tools to move towards an equity framework. And everybody gets the box graphic. I don't know why. I don't know where this graphic came from, but for some reason, the box graphic is the thing that knocks this into folks' head. So if we are not intentional, emergency responses will reinforce underlying structural racism. I've seen it. I've been doing this since 2004. Every response that I've been part of that hasn't stopped and thought and refocused has reinforced structural racism. And you've written a paper 4 years later and you felt really bad about it. And now it's time to stop doing it. So let me tell my personal story about my experience in the U.S. Virgin Islands. And the mission we did was very limited, small, one mission among many. And there were so many heroes in that response. And Captain Funk and her team were right there in the middle of it being heroic. And I want to make sure that that's captured in the story I'm going to tell. Because the thing to know about all of the territories that I want to make sure we say plainly in this space is that they operate in what's pretty much a colonial framework. If you look at them, they have unfair CMS reimbursement rates. They have limited authority over all kinds of things. They are designed to be weak structures governmentally, not empowered the way a state is. And so when you go into a place like that, the nature of the structures of power that you use is important, right? It speaks to the mission. So the experience that I have is the structures that we put in place as a nation. Well, first, let me talk about, I got a little ahead of myself. Our mission, right, was to go down and help the local health department to craft a recovery plan. Me and a team of 5 experts, we were working with the leaders of the health and medical infrastructure in the VI, along with Natalie Grant and Captain Funk and a bunch of federal authorities to build and craft a recovery plan. That was our job. And we were approaching it from an empowerment framework. How do we empower locals to craft a plan and to grab it and run with it? So when you go to the Virgin Islands, and we were living in the FEMA cruise ships. Everybody, if you deployed, you maybe lived in a FEMA cruise ships. And tactically, I totally understand why you deploy a cruise ship into the harbor of a territory because where are you going to base, right? But at the same time, what do you create? You create a little fortress. You create a fortress, almost a militarized fortress with the American flag everywhere and uniforms everywhere. And then inside of an abandoned Radio Shack in a strip mall, you build out a high-functioning, high-tech command center that is sequestered away from the life of the people. And then you build a command structure that is only accountable to itself, a federal command structure that, to my point, wasn't fully integrated with the local structures of power. What you are doing in some ways is you are recreating an authority of colonization in the space through emergency management. Does that make sense? You're creating a new power center, and although you're maybe paying lip service to the idea that power center is supporting the locals, what you're really doing is you're saying there's a new boss in town. And this is not to speak to the intent of any of the heroes who worked within that structure. This is not about personal intent. This is the way the structures that we are within kind of create us and force us to act in ways that are uncomfortable and get in the way of our mission. And for me, the lesson was, and this is us standing with Ruben Malloy, who was our handshake in the VI, empowerment is not a great framework. It smacks of a savior framework. Who are we to empower you in your homes to do the job you need to do? Who are we to do that? I heard so many responders in these situations, and we sent assets to Puerto Rico, we sent assets to the Virgin Islands, and we sent assets to Florida, we sent assets to Texas. Only in Puerto Rican missions and VI missions did I hear the locals called incompetent. All the time, over drinks. And I'm trying to be candid in the room. Why can't these folks get it together? And the reason is because they have been structurally deprived of resources for 100 years. They were created to be incompetent because of the structural frameworks that they are trapped within. That's what I think about colonial frameworks. And so this is some art in the Virgin Islands that we were experiencing. The thing we have to learn is how to fit our resources, which are so needed, and our expertise, which is so needed, within the spirit of a place in a way that acknowledges that we are not the heroes in this situation. And so when I came back to New York City, we had to wrestle with these same things because we have done the same thing. We did the same thing in Sandy. We did the same thing in H1N1. We did the same thing in Ebola. This is not a federal territory problem. This is an emergency response problem. And I wanted to wrestle with it. I wanted to say, all right, guys, sit down. Let's fight the fight. And so we went through internally a GARE tool process, the Government Alliance for Racial Equity. I don't know if you guys know that group or not. They have a tool that lets you sit down and look at your processes and interrogate them from an equity framework to see what you should do about it. And so we went through a 6-month intensive process where we had focus groups with our incident command leaders, incident command staff, our community workers, surveys that went out. And it turned out we were not as cool as we thought we were, right? That's why I want to be so clear about my own fallibility in our process, right? And especially as a person from my background speaking about structural racism, I want to be so intentional about this, but I want to give you practical stuff. What was the problem we found? Our community leaders felt that we in New York City were not including them. Locals complained to the feds all the time, well, you're not including us, right? Well, the community said, you're not including us. You're telling us to go hand out flyers, but you're not letting us strategize about how to work in our communities. So what we've done is we've actually brought the community leaders into our ICS framework. They're in the incident command system. There's not a separate system. There's not a separate bunch of meetings. They are right in there with us, which is a dangerous and difficult way to do business. People bring up spoilers, right? But if you're going to make a unified framework, it has to be that way. We heard that, hey, health department, you are great at advocating for racial justice right up until the emergency alarms go off. That's when you get scared because you get in a room with the cops and the firefighters and the emergency managers and everybody else. And then you want to say yes, sir, and no, sir, because the mayor is pounding on his desk and he's saying, get the job done. And if you're going to do this, you have to understand that advocating for racial equity means that it is part of your emergency response function. When you are asked for an assessment of a disease or a disaster and what the health impact is, you better talk about racial equity or you're not doing your job. And so that is something that we have taken up this year. Our staff of color within our health department felt really alienated from the decision-making process. They said, look, we are from these communities. We were from the West African communities during Ebola. We were from Zika impacted countries, and you are not listening to us. And so we have put in place objective criteria for our ICS leadership. We're trying not to choose our ICS leaders based on gut, based on, oh, I think that person's the best person, but let's have an objective pathway for it. And we're trying to change the training of our leaders to not train them in emergency response, get it done, get it done, get it done only, but to train them in humility and cultural sensitivity and the art of listening. And we've written into our accountability metrics and our evaluation frameworks that our incident commanders will be accountable for advocating for racial equity, both inside of our structures and outside of our structures. And finally, the final 3 things I guess I want to give you. We've tried to figure out how to build this idea of intentional equity into our response systems. Because when we've done it before, when we changed paths for Zika, when we said during Ebola that the police department couldn't be in charge of monitoring the West African case contacts, even though their Missing Persons Bureau wanted to have that job, it was because our commissioner stood up. And we needed to help make the system stand up. So we're running right now our preparedness projects through its own version of an equity analysis. We are building a new vulnerability framework that's based on the Social Vulnerability Index, but includes a number of other racial equity calculations that we can use to do neighborhood vulnerabilities. And in particular, we are changing the principles and practices of our response system. We are building into the system the idea that emergency management is not a charity. That is not what we are doing. We are acting in solidarity with our fellow residents who are having problems. We are an agent of government. That means we are them working for them. We are starting from a place of humility, not heroism. where the survivors are the heroes in the situation, and we're trying to make emergency management more of a community organizing framework than a response framework. Because emergency management, it's all about collaboration and coordination, right? That's what it's about. And so those are the frameworks we want to begin on. So we are making sure equity is part of our agendas, that we're decentralizing decision making, and we are trying to prioritize locals knowing over our bosses knowing. That's the hard one, right? Getting information out to the locals before we tell our bosses. But that's where it's needed, right? When you get information into those hands, we're there. And we're trying never to develop a mission, because what we want to do, we're smart folks. We want to whiteboard it. Tell me the problem, I'm going to develop a mission. We're trying never to develop a mission without informed community participation. Because as soon as you develop a mission and get feedback on it, when you ask for feedback from the people that are most impacted by a disaster, they're in the worst position to give it, right? They're in this state of shock. And so you can't do it like that. They're going to just say, thank you for being here. Whatever you want to do is fine. You have to do the mission development with those impacted communities. Woo. I'm going to take a breath. That was a little bit of a rant. And I saw 5 minutes and I was actually grateful. I was like, I have 5 more minutes. I never felt that way before. Usually I'm over time. So all of that is to say this. It's all about the delta, right? In responses, we're always talking about the delta. What's the difference we're making? What is the change we're making? And the lesson I want to give to you as kind of an outsider, okay, as a person speaking from structural racism, trying to own my own role in that privilege, trying to do good intentionally, is that equity is not a moral force. I mean, it is. It's a moral choice. We need to do it. Equity is essential to the success metrics of a response. Because in a response, you're trying to recover from the emergency. You cannot do that effectively without a clear understanding of the role that especially racial equity plays in the frameworks you're doing. You're just going to fail. So you've got to do it, or you're going to get called before Congress. You're going to get written up badly in the papers because you haven't thought about it. And the other point is, when you talk about building back better, you cannot do that without equity, right? Building back better means building back equitably. It means using the disaster as a policy window to unpack the racial injustices that are present in that situation and that created the impacts to the disaster, and then using the power and force the disaster recovery brings to heal some of those inequities and put them on a path towards resolution. Because a more equitable community, I guarantee you, is a stronger and more resilient is a stronger, more resilient community when the next disaster hits. Purely as a matter of practice, we must integrate better equity frameworks into our emergency response protocols. Thank you.
Good morning. And on behalf of the governor of Puerto Rico, Ricardo Rosselló, and myself, thank you so much for what you did for Puerto Rico. Here is a lot of faces that I remember from those days where Puerto Rico was struck by Hurricane Maria and excellent response. I am very proud of all of you. And I am proud of being an American citizen and an American soldier too. So thank you so much from the bottom of my heart. I become very emotional because it was very difficult times for me. Well, let's see how I move this here, right? Good. Before I start with the what the CDC really uh, did for Puerto Rico and they are doing for Puerto Rico, it's better to start to address how is the health system in the island, because it's totally different from other states, from other territories. You have to remember that Puerto Rico have a population of 3.4. So just remember this: it's like to be in the is the same population more or less of the state of Connecticut. But in terms of healthcare, we don't have the same parity as Mississippi, that is the poorest state in the nation with the more socioeconomical problems. That is something that make it a little bit difficult to deal with the health system in the island, knowing that most of the people in Puerto Rico have are medical indigent. When we have to recognize first, when we deal with the health system, that we have to understand the importance of public health and the impact on the communities and people with vulnerabilities. Also, the importance of having an historical background about the development of the Department of Health among the years, and where we go, where we started and where we go. Once we have that, we can establish public policy in order to address the social problems and health problems of the community. The health system in Puerto Rico is responsibility of the government. So if something bad happen, they blame me. So among the years, it has been a big challenge in Puerto Rico to give quality health care. Why? You as well know that Puerto Rico is under the control of an oversight board by the Congress because the financial breakdown that happened many years ago. So that it creates a challenge in terms of accessibility and recruitment of health professionals. Also, because all of the health professionals in Puerto Rico have the same preparation and qualification, and come from academic institutions that are accredited with the same accreditations from the United States. It's easy to any health professional Puerto Rican to migrate to the United States. So that is causing a big problem in Puerto Rico because we there is a big drain of health professionals in general in the island. So less health professionals, more challenge to offer health services to the population. And you add to that the increasing cost of delivering the health care to people. Well, uh, the Puerto Rico economical model after 1960, that was a big year because that was when the private health insurance started in the island. Before that, all of the responsibility was addressed by the government. So it was like a universal health services. The government will have the total responsibility of the population. And in 1960, they start the private health insurance, and that created a dual system, a system that was administered by the government and a system that the health insurance took care of offering services to the population. Some facts about the Puerto Rican Health Department and health system. From 1820 to 1949, the government was responsible of the care of the population. 1916 to 1919, the commissioner was part of the governor cabinet. I want to mention that on 1898 was when the United States started to administer Puerto Rico. The healthcare was on charge of the of army officers, medical officers of the army that take care of the health system. The law that established the health department in Puerto Rico was from 1912. So it's the what it was one of the first department made in Puerto Rico by the American Army physicians. and was not until 1917 that was the first Puerto Rican appointed Secretary of Health. So you can see the development of the health department among the years. So now the practically the health system uh, involve this. The public sector serve approximately 55% of the population, and the private sector attend the 45%. We uh, we have different health reforms. The first reform was the regionalization of the health system in the island where they appoint 7 regions with regional hospitals and primary, secondary, and supra tertiary care. And for those that doesn't know about it, there was a doctor called Guillermo Arbona that received a grant from the Rockefeller Foundation, and that's how the health system was built in Puerto Rico. Have a organization and a structure at the beginning. So many people doesn't know that the Rockefeller Foundation was the one that put the money for the study. And we have a second reform where the administration of the hospital went into private hands, and was not until the early 90s when they make the health reform, where the government hire the medical insurance to give services to the medical indigent population. The from 60 hospitals that the government have, they sell it, and we only have 7 hospitals, and this is named like the best. The most social justice program in Puerto Rico, because people that we have a dual system where people have to go to that doesn't have a private medical insurance have to go to government hospitals. They don't have any choice. Now the patient can go to any physician, to any private or government hospital to receive their health services. So that is a synopsis of the health system. Okay, so what makes Puerto Rico different in comparison with other territories? First, is in the Caribbean. It's in a seismic region, so we are in a big threat of having an earthquake. That is something that we have to deal with. That we are in near the, that we are also susceptible to hurricanes, and you name it. We can have tsunamis. We can have any major disaster, natural disaster that you can imagine. We have 78 municipalities, diverse topography, and it's a connection with the Americas because many people from Latin America come to Puerto Rico first before they come to the States. So it's like a bridge between Latin America and the United States. Okay, in terms of population, this is the on 2017 there was 3.4 million people. We think that now there are like 3.3. A lot of people that have migrated, especially during the months of July and December. Uh, this is the demographic of the people in Puerto Rico, and as you see, the level of poverty is 44.9%. So we are worse than Mississippi. And in terms of healthcare, Mississippi received $5.3 billion for their Medicaid program. Puerto Rico only received 1.8 billion from the federal government. So you can see the Mississippi have a population of 600,000 people in comparison with Puerto Rico that have 3.3. So that is a big problem for us. And as I mentioned before, 61% of the population is covered by the government insurance. Health professionals are leaving the island. the challenges that we have after Maria, well, as you know, just imagine that you went to sleep on a 19th of September 2017 and you wake up on a 20th of September of 1945. That was really what happened. No communication, no power. From 68 hospital, we only know about it of 17 only, and people from HHS and DOD was our runners that took the lead to go to the distant places of the island to give us information about the condition of the hospitals and CDTs, Center of Diagnostic and Treatment. Can you imagine that? No communication, roads obstructed by debris. Nobody knows anything what happened. We don't know anything. We was completely blind. Uh, in terms of healthcare and public system, we have a big threat. Uh, we stopped the campaign of immunization of influenza that we started on July. We stopped it, and after Maria, and we don't start it until October 9 of 2017, and was because the help of the CDC Foundation, Direct Relief, and other NGOs that help us to get vaccines, because all of the vaccines in the island was damaged because there was no power. By that time we don't have any vaccine available. Okay, so can you imagine how difficult it was? And with all of that, we established that campaign, and for the first time in 5 years, we prevent an epidemic outbreak of influenza in Puerto Rico with all of the bad things that happened. So, infrastructural damage, the limited response capabilities that we have. Lesson learned is that when you have that problem, you have to go back to the basics and rearrange everything, because you have to start from nothing. There was nothing to give continuity, so we went back to the basic and start from nothing. And it was, if it's not by the help of the of HHS, the Department of Defense, we really would not come back to what we have right now. The lesson learned was that at the early beginning, I think that for good or bad, the military training that I had helped me to coordinate with the federal agencies the response. And the I think that when you are in an emergency, you have to work as a team. There is not FEMA, there is not HHS, there are not CDC, they are not Puerto Rico Health Department. There is only one health team to bring people to normality and to save life. That was our mission at the early beginning. And one of the problems that we present, that people miss, is that we first get Irma, and between Irma and Maria, there was a hurricane called Jose. So the help that was sent by the United States to Puerto Rico have a was had a big delay because Jose was in the Atlantic Ocean. So all of the help arrived after Maria. So that was the delay in terms of the response. So we have to deal ourselves with the resources that we have, the early response at the early beginning. With the collaboration of the CDC and HHS, they prepared this network mapping of hub and spokes that later they're going to give you a presentation. Commander Elizabeth Barwer, that is there, that worked with us from the beginning in the emergency of Maria, and she's going to explain you more about this tool. Also, the Office of Preparedness and Response from HHS help us to make this Puerto Rico healthcare facility status, where we can practically We identify all of the health facilities, hospitals, CDTs, Center 330, and we make a map that include the type of facility, patient capacity, generators, diesel, emergency communication, blood bank, morgue facilities. So they give us a clue of what we have before the emergency and where we can redirect patients in a case of an emergency. This map is updated on monthly basis, so we have a good clue about what is the situation. Also, this program we get readiness check 48 hours prior to the disaster. We can address a lot of things. They have a rapid disaster assessment tool and a comprehensive disaster assessment tool. Also, the implementation of CDC supplementary recovery and mitigation projects that are already taking place. The community assessment that is very important that was performed by the CDC, environmental health demographic registry that was a big problem because the demographic registry uh, was before on manual filling of of the data. Now it's going to be digitalized. Immunization program, all of programs, all of this thing. Okay, and now what the CDC do to help to prepare. So uh, I think that the best thing about all of this is the teamwork. They help us to in order to organize the federal office of the Department of Health, looking for grants, help us in the recruiting of the best professionals that can help us in the recovery of the health department. So there is a lot of initiatives that they are taking place at the same time, and also the coordination with other federal agencies. I'm going to show you now some pictures of the hurricane. This was made by this photo is from the International Space Space Station before and after Maria. So you can see that we was completely blacked out. Most of these lights that you see is by generators, all of them. The pictures speak for them. Maria is considered the worst disaster in the history of the United States. So now we are in the phase of recovery. This is the bad thing about everything is that the recovery and redesign all of the initiative for recovery in Puerto Rico, they are going to take between 5 to 15 years. That as bad as it was. This was the top health sector trends during 2018. All of the problems that we are having. We was very lucky of having Elizabeth. Now you can come. Yeah, we was very lucky to count also with the NGOs. So now Commander Elizabeth Barwin are going to tell you something about the how the DART demo work. Thank you so much.
Hi, so I'm Elizabeth Irvin Barnwell. I'm the acting chief of the Environmental EPI branch in ATSDR, and we provided technical assistance to Puerto Rico Department of Health for the development of the Comprehensive Disaster Assessment and Readiness Tools program. And so I'm just going to show one small piece of this, and it's the readiness check that was developed as part of the preparedness activities under the HSS recovery activities. And so it is a short survey that can be sent out via web link to healthcare facilities all across the island. It can also be completed using our app. And it just contains a few simple questions, some specific general facility information, and then the geospatial capabilities of the app, so you can see the location of the facility that's completing the information. And then basic questions on communications, power, water, and then current capabilities. And so once the information is completed and the facility sends the survey in, then the database is immediately populated, and then the dashboard, which shows the critical pieces of information, is immediately populated as well. And you can see here the dashboard's blank, and then as soon as it's refreshed, so the healthcare facilities have been the one that I just entered is showing up. And then as each of the facilities continues to enter their information, the dashboard continuously populates, and you can see the differences between hospitals, so that has the 330s, and then the dialysis centers all across the island. And I'll continue uploading as my colleague is entering data rapidly in the back. And so one great piece of this tool is that this information can be integrated across different agencies. And so you can get a very quick snapshot of critical pieces of information, both for preparedness and response, which will allow the Department of Health to prioritize and to strategize deployment of their resources, both pre and post disaster. And then for any of these pin drops on the map, you can just click on it and it brings up some critical pieces of information about that facility. So, okay. Thanks.
Thanks, Elizabeth, and both the presenters. It was really my honor to get to deploy alongside of these two and the many staff in the Puerto Rico Department of Health and U.S. Virgin Islands during the hurricane response in 2017. And I really echo Mitch's comments. So many times people would ask me about, oh, why are things so why is it taking so long for the recovery down there? And my response was always, they've been chronically underfunded for decades. It's, they were hard hit by these disasters, but that's only a small piece of the whole picture of why it's taking so long. And so I really appreciated your comments. For Dr. Rodriguez, as I went to Puerto Rico many times, I've lost track of how many times I've been there. I think maybe 6 or 8. I was really impressed by the staff in Puerto Rico Department of Health really had a heart for the vulnerable populations on the island, and were immediately strategizing about how to reach the people in the mountains, especially a lot. And we were able to come alongside them and help support you in that. But really, you all were the leading force on making sure that those folks were reached and that they had access to healthcare and all of the important things. And I also think about the community of Luisa. Immediately you wanted to do a Casper there and knew that was a low SES area outside of San Juan, and we were able to come alongside and support that as well. And so I was just really impressed with you and your staff's focus on the vulnerable populations and of your communities, and like you said, reaching out to the community leaders as well to inform our response throughout the time. One small thing I have instituted here is an issue of equity. CDC often has the reputation of stealing the data and running and publishing, without. And so I instituted immediately that a state or local co-author had to be on a co-author on every presentation, every publication that we published coming out of the hurricane. And that's just a small piece of something, that each of us can do for equity to make sure that, we're not leaving the people behind that really provided the information and really are the source of the information that we're able to share. I'll take the prerogative of asking a few questions to the presenters, and then I'll open it up to you all. Mitch, you spoke a lot about the response piece and equity, but I was wondering if you could talk a little bit more about recovery and equity, and maybe Dr. Rodriguez would like to too.
So there are two parts to this, because there are two parts of the story that I'm looking at, and one is the Maria response and our small part in that, and the other is within New York City. And one thing I will note about response and recovery is that this question of EMAC support is very difficult in a recovery framework. We went in, we were there for 3 weeks. So many people dropped in and out of these jurisdictions, team after team. Here's a new face, that face is gone in 3 weeks. And it's hard to make a consistent sort of recovery pattern. I often thought it would be great if there was a way to have local partnerships that lasted a long time. Like I would have loved to make a handshake with parts of any of the impacted areas that would last for 6 months, so that you could really be partners in figuring out strategies for recovery. The equity issue in recovery that we know more locally is recovery is really a process of letting go, right? At the end of the day, you want to get out of town and leave community leaders with something that is better than it was before. But I don't actually know how to do that right now. One of my confusions federally when I got to the Virgin Islands was that there were two separate incident command structures set up at the same time, one for response and one for recovery. They were going at the same pace, and I never knew which one to talk to. Do I talk to the response structure? Do I talk to the who runs this or that issue? And so I really think that this issue of figuring out at the beginning your equity analysis, executing against those frameworks, and keeping everybody on track to the same vision, that's really the important thing. And I think the entire way we do missions is against that, because the missions are within subject matter expertise silos, and they're for a limited amount of time. So everybody only cares about their mission. And so you lose this question of big picture vision. So if you could have a forward planning cell that was set aside for that, if it could include local mentors that have gone through disasters, who can keep that, to keep a sort of a bright star ahead of you, I think that would help a lot, because we get distracted mission to mission.
Did you want to add anything?
Yes, well, we have a lot of experience. I think that the most important thing is teamwork, and you have to have a director of the orchestra. The thing is that sometimes they come different federal agencies,
Yeah.
and everybody is asking you for things, giving you grants and all of that. And sometimes they collide the efforts, because it's the same efforts. And when uh, two positive charges collide, they repel. So nothing happened. so so that so you know what I mean, right? And that is that it happened anywhere, even in the military, in the local government, federal government. So I think that everybody want to help, but we need some director that organize, that put the people together, that they know all of the federal agencies that are trying to help. Like, okay, FEMA, what you're going to do? HHS, what you're going to do? CDC, okay, so you're going to do this, and then you can be more effective. Also, a thing that we learned, that also Asper learned, that never was using a natural disaster, was the help of the NGOs. The NGOs eliminate a lot of red taping from the federal and local government, because they have money, they can act immediately, they can buy things, and it was very interesting that was the first time that they use in a national disaster the NGOs, and works. The first vaccine that we received was from the NGOs, so we don't have to wait for the federal government to bring us the first batch of vaccine. and a lot of help that we receive from different other local non-profits organization and all that. I think that the thing is that we need is a need to have a chairman of preparedness and response in general that take the lead of all of the efforts of the different agencies involved in natural disaster. That is my humble opinion.
Thanks. And one more question for you, Dr. Rodriguez. Certainly we hope that a hurricane doesn't hit for a couple of years. You have time to recover.
I will resign.
But I'm just wondering, based on what all we've learned from this experience and this recovery process, how do you think reaching the vulnerable populations will be different next time?
I think that as I mentioned before, we have a better interaction with community leaders. We visit the communities. We talk with the community leaders that they know really who is the person and the people that really are in need. Uh, if they have some mental discapacity, if they have other medical problems, so we identify the population, and we know right now what are the way that we have to add to that community if something bad happens. We know the people that are, and I think that the is I think that by default, if we want to deal with natural disaster, we have to know the community that we are going to impact. And the only way that we can do it is by doing the assessments. Community assessments are very essential for preparedness and response because they let us ahead know how we are going to react after a disaster. I think that is the lesson, the most important lesson learned from me.
Great, thanks. And with that, I'll open it up to the audience for questions. Judy, you're first.
Thank you so much. It's great to see you talk about this. I'm struck, Mitch, by your last comment when you said build back better. And I think that when we were working in the response to the hurricane, we wanted that, but we felt restricted by what we heard was FEMA's policy, which was to build back the same. And when you start with a vulnerable situation, how do you suggest we overcome that? Is there something CDC can think about in its preparedness work to ensure that we're building back better instead of building back the same as per FEMA's requirements?
Oh, that's a big question. Building back the same is built into the Stafford Act, right? And so there have been a lot of debates about it in emergency management. I think that the strongest argument is actually something like building back the same is building back weaker. Whenever you say we're going to build it back the same way, the arguments that I saw start to change minds were something like, we've rebuilt the U.S. Virgin Islands electrical infrastructure 17 times over the last 40 years. When is that not cost effective? There are these bottom line utilitarian kind of efficiency arguments, cost saving things. So that's one way. I do think that, I guess, let me say two things. I wish there was a policy way to take that naturally took the lessons learned from a disaster and put them into a policy framework. So, for instance, the CMS reimbursement thing, which Dr. Rodriguez went back to, the really, really deep inequities of territorial reimbursement, is something that I think was alleviated temporarily in the Disaster Act. But there's still, if I understand it, a Territorial Health Act that has been sitting on the congressional floor for years now, years and years, that really hasn't been able to get passed. So I think if there was a way for CDC to use its its voice about public health risks and say, we can tell you that tobacco kills people. We can tell you that heart attacks kill people. You know what else we can tell you? Next disaster, these people are going to die because of the underlying healthcare systems, the bad electrical systems. I think that sort of advocacy over time, over a lengthy period of time, is what, if you started it now, would eventually pay off from a policy standpoint. And at the end of the day, you've also got to change the Stafford Act, which is a whole different political football.
And I would just add on to that we had a hard time communicating with FEMA and other federal agencies to understand their mindset about building back is about buildings and structures.
Right.
And we're talking about public health programs. And so these are the staff people who are affected themselves and are victims of the disaster, who are also still trying to reach out to the populations that they serve through their programs and trying to get those programs stood back up. And that was for some reason, was difficult for folks to understand. And I think it's partly just because the system is oriented towards, like you said, rebuilding infrastructure and buildings, but programs are harder to conceive of. Shauna?
Yeah, thank you. This question maybe is initially for Mitch, although Dr. Rodriguez touched on it a little bit as he was wrapping up. But this is about when you mentioned incorporating community leaders into the ICS structure, which is excellent. And we've seen that start to happen a little bit more and more. You mentioned developing objective tools and mechanisms, and you also mentioned those impacted populations are often at their most vulnerable and overwhelmed when an emergency hits. And there's potentially so many community leaders in so many sectors and so many voices. So where do you start, and what is your process? And Dr. Rodriguez mentioned the community health assessments to identify those stakeholders earlier, but actually in the structure and in your response plans, is it multiple liaisons? Is it one person? I mean, what does that sort of look like, and how do you determine who your community leaders are?
I think that the best partner that we have are the NGOs. The NGOs have been done a superb work in the communities. So we are using the NGOs as a liaisons between the Puerto Rico Health Department and the community leaders. So we visit them together. We make efforts. We make also health outreach to the region. Now we are going to sign an MOU with the Army Reserve in Puerto Rico. And also with the Air Force, that they will give outreach program. They're going to make outreach to those communities, and we are going to be involved with them. So they're going to repair things there, cleaning roads, and at the same time, we are going to give medical services. We are going to interview the communities. And we are going to make like a surveillance. It's like a Casper, but with the help of the CDC Health Department and other NGOs and federal agencies, we have to. The most important thing is that I think that a Secretary of Health in a territory like Puerto Rico cannot be a Secretary of Health for being in office. They have to be in contact with the people because it's the only way that the necessity. I think that always a government official have to live and suffer with the people. They cannot be in an office and alienated of what is going on. And I think that maybe my preparation, the way from where I come from, uh, help me a little bit more in order to understand how to approach those problems. So I hope that by the end of my tenure, we can have a good analysis of the communities in Puerto Rico, and for the next emergency, we know how to react and respond depending the area of Puerto Rico. At the present moment, the most vulnerable area in Puerto Rico is the mountain region. It was the one that suffered the direct hit, winds up to 240 miles per hour. So can you imagine the devastation that you saw the pictures there? Uh, so I think that we identify the more vulnerable. We focus there with the NGOs. The NGOs, as once again, the NGOs and the nonprofit organization are partners of the Department of Health in that endeavor. So I think that that is the way we have to address this situation.
And let me just add a couple in terms of the mechanics of how we do it. We have what we call EPIC, which is the Emergency Partner Engagement Council. And, you know, there are sectors we're funded to reach, the behavioral health sector, the social services sector, across the 11 sectors. And then we have neighborhoods. We're a city of neighborhoods. So what we do is we have a matrix approach where we say who works in each sectors, who are the NGOs and the partners we have in these sectors, and then who are the community leaders in the neighborhood. And then for an impact, we kind of put those together and we say, well, what sectors are impacted in which neighborhoods? And that begins the sort of formal partners. Now, the trick, though, is the real art, and we haven't mastered this yet, is you have to be able to go into a community and listen for the emergent leader. You know, who has emerged in this disaster that is a valid spokesperson, and then you have to not be afraid about letting them inside of your tent. And that part is really making people it's uncomfortable, because that means, you know, they're going to come in from an advocacy perspective. They're going to want to speak truth to power to the system while it's trying to get its job done. And that it slows you down a couple of ticks. My experience is you have to be you have to be really good at the listening and the drawing. If you start that relationship early, in a very short period of time, you're going to have a very productive partnership. But you do have to have senior leaders who are willing to sit there and just take heat for half an hour and take it honestly and listen. And that's hard to do. But if you will have senior leaders that will take that heat, then it's much more easier to build those partnerships during the disaster period.
I think we have time for just one more question, please.
It's actually more of a comment. Thanks for both presentations. I just wanted to say that in listening to Mitch talk about the experiences in New York, it brought to mind for me some of my own experiences here at CDC, both serving during the Zika response as well as serving as an evaluator for a recent exercise where I think that we missed opportunities to take full advantage of the diversity that we have here at the agency. In the task force where I was serving as an evaluator that I won't name, where I observed that had some real impacts on how the folks in the room were responding. And I think that if we had more diversity and could include more voices, it would have made a difference during that response. And I had real concerns that if that was an actual event, you know, what that would mean for those vulnerable populations that were being discussed in the room while I was watching. So I really appreciate those comments, as well as the comment about some of your staff of color feeling alienated and feeling that their voices are not being heard when they are in the room. And I think that's something for CDC to think really hard about and see how we can make sure that we are both representing all of the populations that we serve, as well as giving some of the staff of color an opportunity to get some of these experiences that I think will help us with as we go forward, as folks retire and we need to bring new folks in. And so I really appreciate hearing that.
Craig, did you want to come back up? Oh, is there a question from IPTV? No.
Okay. Thank you. Very, very informative presentations and very good Q&A session. Okay, our 10-minute break has turned into a 1-minute break. No, just kidding. Let's take a very short 5-minute break. We're just a few minutes behind schedule, and we'll come back and get started. Thank you.